And we are going to present a case today, and our presenter is Dr. Nazish Misbah. He is Infectious Disease Fellow 2 at SMBB IT and CHK. So let's start the case. I'm Dr. Nazish Misbah, and fellow at SMBB Institute of Trauma Center and Civil Hospital, Karachi. The title of the title of my presentation today is Uncovering the Mystery, a Diagnostic Odyssey. Then it's a case of 14-year-old boy, student of class 4, with no known prior comorbids, presented through emergency with the complaints of backache for the last 2 months, bilateral lower limb weakness for the last 1.5 months, and fever for the last 5 days. In the history of presenting illness, my patient is quite well, around 2 months back, and he had suddenly had a history of fall in a mud puddle. After that, he developed a sudden sharp pain that was at the mid to lower back, and it was sudden in onset, continuous, radiating to the both back, progressive, making awaken at night, and it was exacerbated with a posture change and relief partially with taking of painkillers. It is also associated with difficulty in walking for the last 1.5 months. That is gradual in onset, and it is progressive, so much so that initially he developed weakness in the right leg, and after a week, there is a weakness developed in the left limb also. It was associated with loss of sensations of the lower limb, and he became bedbound in over 20 days. It is also accompanied with simultaneous urinary and bowel incontinence. It is not associated with weakness in the upper limb, difficulty in swallowing, breathing, and it is also not associated with fits, altered level of consciousness, visual loss, and weightlifting. My patient is also complaining of fever that is only for the last 5 days. It is sudden in onset, high grade Tmax documented around 102 degree Fahrenheit, and it is continuous, not touching the baseline, relieved only temporarily by paracetamol, not associated with rigors, chills, headache, vomiting, sore throat, hair discharge, burning maturation, and rash. He is complaining of backache, not appreciated generalized body ache with this. In a systemic review, in general, he had no history of weight loss overall, oral or genital ulcers, lumps and bumps in the body. Respiratory system is also unremarkable, while CVS is not complaining of any chest pain, dyspnea, syncope, or palpitation. In gastrointestinal, there is no history of abdominal pain, vomiting, diarrhea, constipation, or jaundice. Musculoskeletal is also unremarkable, and endocrine system is also unremarkable. In the past history, there is no previous hospital admission, there is no history of TB, blood disorder, or blood transfusion, and no history of any surgical intervention. He is vaccinated according to API schedule according to the father, but no record was available. In the personal history, his appetite was decreased, sleep disturbed, bowel habits, he is fecal and urinary incontinent. Addiction was not there, no history of traveling, and sexual history was unremarkable. In the family history, his parents is alive and healthy. Father is a shopkeeper and mother is housewife. All other siblings are healthy. No family history of similar illness or tuberculosis. In the drug history, apart from occasional painkillers, there is no history of any herbal medication. Socioeconomically, he lives with the family in an own house of 2 rooms, which is quite airy, drinking tap water and unboiled milk, buffaloes and goats at home. Okay, on the basis of history, and I would like to ask audience, what will be the differential diagnosis?
Please summarize your history.
Okay. My patient is 14-year-old boy with the complaints of backache for the last 2 months, along with lower limb weakness that was associated with bowel and urine incontinence and numbness of lower limbs and fever for the last 5 days. Any differentials where anybody want to ask? In the history?
Brucellosis, tuberculosis.
Okay. I would like to the fellows to respond.
Okay, so the history start within a trauma. So there may be the traumatic infection that leads to the spinal cord involvement that has led to the paralysis of the lower limbs.
There is no issue.
So infection may cause tuberculosis, brucellosis, and osteomyelitis of any bacterial cause can be the cause.
Can you repeat it? Tick bite. No, there is no such history of tick bite. Can you hear us? There is no history of any cats at home. Okay. So the yes, Staph aureus, but osteomyelitis. Anything else?
So I sorry, came a little late. एक line के अंदर क्या? Just history in just one line. This is a imtihan for you.
Yeah, this is okay. Okay. This is a case of 14-year-old boy. A 14-year-old boy with a complaints history of backache for 2 months, lower limb weakness for 1.5 months with a accompanied bowel incontinence and fever for the last 5 days. It's only a just history.
Okay, so can I ask why somebody asked for tick bites? What were the differentials there thinking about tick bite? Amna, you can unmute and talk. Amna. Okay, while we're doing this, rickettsia, which one? हजारों rickettsia हैं. मैं इम्तिहान पॉइंट से पूछ रहा हूँ because अगर आगे बोलेंगे तो आप फंसेंगे. So you have to have some. So which rickettsia were you thinking of, which will cause lower extremity weakness and fever, right? यही था.
Yeah.
And then similarly, Kurtulain, why schistosomiasis? Or which schistosoma were you thinking about, which would cause fever and weakness? Mansoni, hematobium, or japonicum? Oh, आपको जवाब नहीं दे रहा. And Memuna, why cats? Sorry. They're good questions, but why?
अरे मैंने तो बार्टनेला सोच के ना मैंने कहा डाउन द लिस्ट मैंने कहा चलो बार्टनेला आल्सो कॉजेस रेडिकुलोपैथी तो फिर मैंने कहा चलो बाकी एक आधा डिफरेंशियल तो ये पूछ लो.
सही है. That's नहीं ठीक है. बार्टनेला बिल्कुल हो सकता है. I guess we don't know anything about history beyond this. तो हो सकता है कि वो बड़े-बड़े नेफ्रॉन निकालेंगी and हम कहेंगे बार्टनेला. So okay. And staph, TB, brucella are obviously the for a vertebral osteomyelitis, I think is what your differential is. Yes. Okay, chale. Sorry, I had to intervene. I was just curious what people were thinking.
Sorry, special. Just let me repeat the history in one sentence. This is a young boy
who has back pain for 5 months and then weakness, 2 months, and then weakness of lower limb with fecal and urinary incontinence for a few days. It's not for 5 months. And fever was something new for him. Okay, that was from 5 days. So it's not that fever with weakness. Basically, it's back pain with weakness, and later on he developed fever, which is a new thing for him. So it was a new fever.
Okay, because I mean, you could think of simple things too. I mean, this could be some sort of radiculopathy leading to UTI, maybe, right? So because of bladder incontinence, so simple things can. If fever happened later on. All right, Chandni, I guess we could go on. I'm sorry I hijacked.
That's good. Sorry, our screens again get stuck. Okay. All right.
Okay, so what are differences were? Initially, there is a history of trauma because he slept in a mud puddle. So non-infectious causes include heart compression, secondary to trauma. It can be due to the tumors, neurofibroma, schwannomas, CIDP, multiple sclerosis, autoimmune disorders, ankylosing spondylitis, acute intermittent porphyria, because quite long history with short duration of fever. The infectious causes, as we have in an endemic country, Pott's disease with paravertebral abscess, another differential, and cystic lesions. Transverse myelitis can be with multiple reason are there, so with HIV, HSV, dengue, neurobrucellosis, neurosyphilis. So all these came into transverse myelitis. So these are our differentials on the basis of history. Okay, moving towards the examination. My patient is young male. He's sick looking, thin and lean built, oriented and cooperative at the time of examination with a pulse of 102 beats per minute, and it was regular with a BP of 100 by 76 millimeter of mercury and a respiratory rate of 20 beats per minute. He was afebrile with a 37-degree Fahrenheit centigrade, and he was maintaining 96% on room temp. He weighed approximately 40 kg and of a height of 4 feet 10 inches and approx BMI on that basis of 90. In the general physical examination, his oral hygiene is poor, while conjunctiva was hyperemic, while rest of the general physical examination, including lymph nodes and other findings, was unremarkable. Right. In the CNS motor examination, the upper limb was normal with a motor and sensory as well, while the lower limb, in right lower limb and left lower limb also, there is a generalized decrease in the bulk with an increase in tone and power of 0/5 in both limbs with exaggerated reflexes and upgoing bilateral planters. With the ankle tonus present on the right side, while it was not appreciated on the left side, and a joint position and sensory is also lost in both ways. Okay, the higher mental functions intact, and all cranial nerves was also intact. Spine, there is a tenderness appreciated at the levels of lumbar vertebra with no gibbous formation at the upper. And sensory mapping also done with a decrease below D10 level and absent below D11. Cerebral sign in the upper limb was normal, while lower limb cannot be assessed, and gait is also could not be assessed, while signs of meningeal irritations was absent. Abdominal examination inspection was normal, and in palpation, the liver is palpable 1 finger below the costal margin, while rest of the examination was unremarkable. As respiratory and cardiovascular examination is also unremarkable. The case summary: it's a 14-year-old boy admitted with a complaints of backache for the last 2 months, with a bilateral lower limb weakness for the last 1.5 months, and fever for the last 5 weeks. On examination, he was average height and thin build, lying on a bed with a CNS bilateral lower limb weakness of 0/5 with increased tone and exaggerated reflexes. Planters bilaterally upgoing and ankle clonus on the right side with a sensory level at D11. Okay, now I would like to, from audience, what will be the differential diagnosis on the basis of history and examination?
Do you want to add something or?
Same, मेरे तो same differentials.
So उनसे क्या मतलब है same?
I'm going same brucella leading to whatever paravertebral abscess or the spinal cord compression or Pott's disease and third one from any bacterial staph or strap, whatever.
Okay, do you think this fever is correlating with this?
Fever related to what?
With this condition? Initially, he's presented with the weakness, right? And fever is only for the last 5 days. And there is a history of trauma as well.
So he might have a weaker spine secondary to prolonged infection. He might not be spiking fevers, maybe.
Okay.
So could it be because of the patient is having traumatic cord compression and now he has presented with new onset of fever, maybe due to malaria, enteric, or some sort of bacterium?
Yes. Why not? Someone asked Kashif Farooq and asked about the
So
sexual
सादी आपकी
history.
आवाज बहुत हल्की हो गई somehow.
अब आ रही है?
Yes.
क्वेश्चन चैट पे है डॉक्टर काशिफ फारूक की तरफ से सेक्सुअल हिस्ट्री. देयर वाज नो सेक्सुअल हिस्ट्री और इट वाज अनरिमार्केबल. Anything else? So you want to keep all the differentials, ठीक है?
Well,
Yes.
looking at the chat and the comments, I think people are going more towards fever from some other cause and the back from some other cause. That's what I think the general consensus seems to me.
Okay.
So मेरा नहीं है, ऐसे मेरा है कि fever और backache एक ही है. Is this possible कि patient after fall he had transient bacteremia? ऐसे पता नहीं, मैंने कभी ऐसे देखा नहीं.
Everything is possible in the world.
गिरा वो बहुत दिन पहले था.
So we know that I don't know about bacteremia, but we know that post trauma you can have reactivation of staph. There's an echo.
So was the patient mobilized or he was bedridden and having tubings in place?
He was not catheterized, but he was bedbound. He was bedbound. Okay, now moving towards our differentials. Keeping the what's again here, paravertebral abscess, again neurobrucellosis, neurocephalus there. Cystic lesion cannot be ruled out also. And non-infectious also cord compression like secondary to trauma, space occupying lesions, multiple sclerosis can be a possibility, and autoimmune disorder in a young child can be a possibility, right? So now moving towards the investigation, what we have done in this patient. Okay, starting from the hematology and hemoglobin, initially when the CB says its HB is 15.2 with a hematocrit of 43.2 and a normal MCB. Over the time of 1 week, it decreased to 10.8. TLC was normal with a predominant lymphocyte count and with a reverse of pattern over week, and platelet count initially 180 and it over the week it becomes 350. with a normal ESR and a biochemistry almost towards normal. Okay. Then we send the acute febrile illness profile, in which blood culture was sent, that growth of staph epidermidis was there, and we taken as a contamination. Urine culture, there is no growth. Dengue IgM was reactive, and dengue NS1 antigen is also reactive. MPICT was negative. Viral profile is also negative, with VDRLs also non-reactive. Okay. Test X was done. It was a
Did I freeze or everybody else freeze?
It's frozen.
Sadia, you froze. डेंगी का धमाका फेंक के आप फ्रीज हो गई।
आवाज आ रही है?
अब आ रही, अब आ रही।
ओके, वो कुछ थोड़ा सा सिग्नल्स का प्रॉब्लम हो रहा है। सिर्फ एक्सरे का पूछा था मैंने कि एक्सरे पे कोई कमेंट या नॉर्मल है?
So Kotlan says seems normal.
yeah, yes. Looks like
Yeah, it's normal.
X-ray. Now this is X-ray lumbar spine. Anyone can comment on this lumbar spine X-ray?
It's difficult to say. It looks underexposed.
Yeah, it's underexposed, but we
overexposed.
But we can
There is a
delineate our vertebrae with the
Wait. Vajad is saying something. Ji Vajad.
Sir, there is destruction of the vertebrae at the just one vertebrae C of above the mesh here right now.
Yes. It's above S1. It's not S1, but you are right. There is something wrong with the vertebrae.
but where
But at what level? Again, they can't hear us. Okay, next.
okay. If we see the vertebrae on the level of D12, you see the last vertebrae is on D12 level, right? On the D11, if you see, there is a lucency on the right margin, right aspects of the border, vertebrae border, and there is loss of pedicle. Can you hear me?
I can hear, but I can't see. I mean, I can't see what you're talking about. Can you put your arrow?
Yes, we can hear.
Yes. This is the lucency at the right border, right? And there is a loss of pedicle, which showing the erosion of the vertebra, right? Okay, now moving towards the MRI lumbar spine. We move towards the MRI. If you shoot this sagittal section, there is an hyperlucent area at the level of D11. And when I go through axial scan, right, this is the axial T1 and T2. This is T1 and this is T2 image. Can anybody elaborate this MRI axial image?
I can see something's wrong with it, but maybe something.
But where? Okay. If you see the border, this is T1 and this is T2. There is a hyperintensity and loss of vertebrae at the level on the right side, with a compression of the spinal cord and something pushing, paravertebrally pushing inside the spine, right? If you see left side of the pedicle, that is uniform formed by the anterior and posterior pedicle. So this vertebral body is quite smooth while this is lost, and something is pushing inside the vertebral column and compressing the spinal cord, right? So
what are the differences now?
Spinal abscess.
spinal abscess. Thank you very much. Bacterial, fungal. There are a lot of causes of spinal abscess.
Dr. Sadia, आप दोबारा गायब हो गई.
Sorry?
आपकी आवाज चली गई दोबारा. अब बोले. We couldn't hear you.
Okay. So I was asking about what could be the differentials now. So मुझे एक आवाज आई थी spinal abscess की.
Yes, Dr. Sadia, मैंने कहा था spinal abscess.
अच्छा, मैंने कहा ठीक है. So अभी Purazil is saying कि staph abscess like Pott's disease. ठीक है. Anything else?
Brucella, I'll keep Brucella क्योंकि unpasteurized milk intake था उसकी और goats थी उसके पास तो.
ठीक है. Brucella usually abscess करता है.
नहीं करता है, मुझे लगता है नहीं करता है, इसीलिए क्वेश्चन.
There is a mass which is pushing the spinal cord. ठीक है. यहाँ पे जो osteomyelitis है वो तो ठीक है, लेकिन ये mass है जो कि spinal cord कर रहा है. तो Brucella, yes, one of the differentials, but lower down. Okay. आगे चलें ना प्रोफेसर.
You were the boss.
No, you are the boss. Okay.
This is the MRI report, and that is showing hypointense on T1, hyperintense on T2 with no contrast enhancement. Intradural cystic lesion displays in cord left side. It has a component in the right paravertebral region. Dorsal spinal cord lesion likely cystic or neoplastic, while rest of the MRI, including brain and lung sections, are normal.
So I was going to say that, I mean, it did usually infection doesn't cause a cystic lesion, right? That didn't look very, that's more destructive than.
So this is a diagnostic odyssey.
So yes, the Purazil.
तो आपकी आवाज हट गई, आपको करीब आना पड़ेगा.
Okay.
Yes.
Now in the chat, Purazil has answered cysticercosis. How many of you agree with her?
You can raise your hands, those who agree, or if you go in the reaction button, there is no, there's not. So you can raise, those who agree, give a thumbs up.
Achha, Maimuna too.
Thumbs up on your reactions button. And if you don't give thumbs up, then you have to unmute and say why you disagree.
Yes.
Okay, Mehtab has agreed in duress. Or nobody else agrees? Okay.
So what
And Maimuna agrees.
What are the differences of the cystic lesions other than cysticercosis?
Wajid agrees fungal. Kurtan says fungal.
Fungal, yes, Kurtan says fungal. Cystic lesion. Which of the fungal infection causes cystic lesion? Hydrated from Zahir. Hydrated causes this. Neurocystic involving brain primarily, then spine. Okay. Most of them are saying hydrated cyst. Okay. Why not a cystic neoplastic lesion in this age? Usually the younger children can have a cystic neoplastic lesions in the spinal cord. Why don't anyone of this? It's just
because we're an ID CPC and not tumor board. I think that's right.
Yeah, this is the reason. But there's one important thing to like. There are cystic lesions, neoplastic lesions, which can occur in a younger age of people. So you should keep this thing in mind whenever you have a cystic lesion in the spinal cord, especially in the younger people. Okay. So let's move forward.
Okay, the hospital patient remained hospitalized with limb weakness and fever treated as dengue, right? And now what? So limb weakness, for limb weakness, we a neurosurgery taken on board, and patient taken for decompression of the spine, and these are the operative findings. Can
So can anybody explain this?
okay.
So that is what?
Daughter says, Memuna says, daughter says, question mark.
Yes. Doctor says. Acha. Now we show you this surgical findings.
Okay.
Okay, I agree with Dr. Memuna's assessment of, wow, that
Yes.
looks like Aliens the movie. But okay.
Intraoperative findings are excision of encapsulated extradural lesion over like a spinal cord at D11 and D12 with a small rounded translucent substance, likely protoscoliosis, lesion likely spinal ID cyst with few cyst structures during removal. Right, now what next? So now we are looking for dissemination of the disease, if there is any other. As I already told, MRI spine and along with that lung and brain section was unremarkable. Ultrasound carried out to see the liver cyst also, but it was also unremarkable. And the histopath came out and it was multiple fragment of cyst wall with the cyst has acellular laminated wall and the inner germinal layer scattered scoliosis are seen and features are compatible with hydrated cyst. So our final diagnosis is spinal hydatosis and dengue fever.
Okay, there's a comment from Amna. There has to be
Sadia
followed-
Tareeb.
Okay, sorry. So there's a comment from Dr. Amna. Paired had to be followed during surgery. Basically, the neurosurgery people are of the opinion that probably this is a cystic neoplastic lesion. So it was surprising for them to have a find out that hydrated cyst on during surgery. So they were yes.
Spinal compression is an acute emergency and we have to relieve the compression first. So it was carried out for operation.
Yes, and later on, his IHA data was sent and it was raised.
Good.
So now,
Now moving post-operatively, patient remained well and discharged on albendazole 10 milligram per kg BIG. And on follow-up, patient looked well when he came after a month, and power regains to flickering toes movement only, that is 1/5, and fecal and urinary incontinence improved after 1 month. And now, any question up till now?
None from my end.
Okay, now moving to the literature review with the hydrated cyst. Echinocosis is basically a parasitic disease caused by the infection with tiny tape forms of genus Echinococcus. And it's classified either cystic echinocosis or alveolar echinocosis. Cystic echinocosis, known as hydatid disease, is caused by infection with the larval stage of echinocosis granulosus. It's around 2 to 7 millimeter long tapeworm, and it's found in dogs. It's a definite host, as our patient has goats and cattle at home, but dog is everywhere around us, right? And sheep and cattle, goats and pigs are intermediate host. Although most of infections in humans are asymptomatic, and it's harmful, slowly enlarging cyst in the liver, lung, and other organs, and often grow unnoticed and neglected for years.
So there are a lot of, sorry to interrupt, there are a lot of questions on chat. So Kashif has asked the duration of albendazole. So probably in this case, I don't know, but he's been on albendazole from last 6 months, right? And we have done his MRI twice with no more cystic lesion, because remember, he has rupture cyst during the surgery. The second, and the second question was that was albendazole started pre-op? No, it was started post-op because of the urgency. Neurosurgery has to do the procedure because of the cord compression, and they were suspecting more of a cystic neoplastic lesions rather than the hydatid cyst. Yes, serology was positive. That's it. How long was it continued the post-operative removal? The hydatid for albendazole for lifelong.
And cystic echinocosis, have you we answered clearly to up till now?
Yes.
Okay. Cystic echinocosis is basically asymptomatic, mostly grow until it gets large, and mainly found in liver and lungs, while the spleen, kidney, heart, and bones, including central nervous system, brain, and eyes, are the rarest site. Right, while the multilecularis, which cause alveolar echinocosis, because of the marked difference in epidemiology and clinical features and diagnosis and treatment, it was mostly found in Europe, Russia, Central Asian public, and transmitted by foxes and dogs, may be asymptomatic and behaves like a malignancy. This is the life cycle as a definitely host is dog and intermediate wild, and human is that dead hen host with infected by taking fecal-oral route like drinking water or meat with an embryonated egg in the feces, right? And the diagnosis is mostly history of exposure to the sheep, dogs in an area where it's endemic. And in techniques like CT scan is 98% sensitive, while ultrasonography is 90% sensitive. In MRI, T2 weighted images are morely sensitive in lung cases and used to detect the sex. Serology tests may be used to confirm the diagnosis. In serology, cystic echinocosis is one of the few parasitic infection on which diagnosis is based. Primarily, ELISA and indirect immunoglycation test for the detection of antibodies, and depending on the test system used and other parameters, approximately 10% of the patient with hepatic cyst and 40% with pulmonary cyst do not produce detectable serum IG antibodies and exhibit false negative test. And cysts of the brain and eye and calcified often induce no or low antibody titer. Children with 3 to 15 years of age may produce minimal serological reaction. So it can be negative in many, right? I'm sharing just standardized classification of WHO because it's help in the management of the patient. As CE1, cystic echinocosis 1, and E2 are the ectic cysts and containing viable proctoscoliosis, while C3 has been subdivided into A with detached endocyst and B predominantly solid with daughter cyst. Basically, this is ultrasonographical classification for of WHO, and on this basis, our treatment based, right? CE1, unilocular cystic lesion with double line signs. It's an active stage, while 2 is also an active stage, and 3, A and B, is a transitional stage, while 4 and 5 is inactive stage, in which most of the treatment don't recommend any treatment. Okay, medical treatment.
So, sorry, I just want to say ultrasound often don't tell you the CE when you send them for ultrasound, especially liver wale. So now routinely when I'm sending them for an ultrasound, I tell them please give CE staging. And what they did aapko. So which is very helpful because some people then I decide not to treat.
Okay, but mostly 90% of the people rely on this. On the medical treatment, if the CE1 and CE3 should be treated with either albendazole if it's less than 5 centimeter diameter, or go with percutaneous treatment if it's between 5 to 10, and for cysts larger than 10 centimeter, continuous catheterization may be an option. Treatment with albendazole in echinococcus granulosus infection can result in apparent cure in as many as 30% of the patient, with further 40 to 50% of the patient showing objective evidence of response when observed short term. Patients do not show obvious initial evidence of response may be found to be cured when observed over several years. And continuous treatment is preferred and has been administered for periods of 2 years without significant side effects, right? Now the surgical treatment is partial cystoparasectomy and Pierce procedures is there. And summarizing this with the albendazole and surgical management with cyst and Pierce and surgery. All right. Now moving towards the literature review, and it's a vertebral hydrated cyst infection with a case report published in Elizabeth in 2020, with a 39-year-old female developing increasing lumbar radicular pain and a functional impotence of lower limb. As cystic echinocosis of bone is extremely rare disease, and spinal cystic echinocosis remain associated with high risk of morbidity, disability, and mortality. And the operative use of scolioside and pre- and post-operative use of albendazole are currently considered to be the treatment of choice for spinal cystic echinocosis. And the hydrated cyst should be considered in differential diagnosis when there are cystic lesions that causes osteolysis and spinal compression to provide the patient with optimal treatment and rapid recovery. This is the conclusion of this literature. Another 2 articles which was published in Pakistan, it's BMC Veterinary Research in April 2021, with the prevalence of cystic echinocosis in animals is around 9%, with a highly prevalent in buffaloes, sheep, cows, and goats, and mostly found in the liver, which is currently showing highly prevalent in southern regions of KPK. Another retrospective study that was based on the 16 years, it was also from Pakistan, and 251 patients from KPK province was enrolled in this study, and came out to be cystic having echinocosis, and it also showing the echinocosis emerging trend in Afghan immigrants in Pakistan and highlighting the transmission of dynamics of this disease. Right, and spinal hydatosis, another review case report in Hindwide in 2014. Again, it's showing it's a rare disease and with a recurrence, multiple recurrence. So, thank you from my side. Any question?
Can you hear us?
So, Memuna has a question. Can serology for echino be false positive?
It can be a false positive.
So the reason of presenting this case was that, as you see, it's mentioned in the literature that spinal cord hydatosis is very rare. This was the reason that whenever we come across with some cystic lesions, so we should keep the neoplastic lesion as well as hydatosis in mind, although it's one of the rare sites where we can see it. The common sites are as we all know, are the brain and the liver. But this is a very interesting case, and one of the rarest presentation we have seen for the hydatosis. So I think the people must. This was a simple case, but I think It was a good case to present. Okay, there is a question that how to decide when to stop. So when we review the literature for the spinal cord, they have said that it should be the lifelong. This person should be a lifelong on albendazole. And I would like to ask Dr. Faisal if he has any comment on this, that how long should we continue the albendazole in this patient?
Yeah, I would also agree lifelong. I've had two people, I think, who are spinal and they're just on the therapy. Ek to Oman se aata, and beech mein he stopped his therapy and the lesions started increasing gradually again. So he's just, I tell him, yeah, please, and he's okay with it. We don't give pulse anymore. We just, remember, it used to be a couple of months on and then a month off or something. So now we just give continuous. We don't give pulse.
Thank you very much. Any further question? Anybody wants to ask something?
Yes, this
Excellent
was a good
case,
case.
Dr. Sadian, excellent presentation. I just have a question, like why some people are prone to hepatic or lung cyst as compared to some are prone to neurological or spinal involvement. Is there any connection or is there any specific reason for that?
I haven't come across while doing a literature review about this during this case. I don't know, Dr. Faisal. More experienced person.
Kya cheez?
Sarah is asking why certain people are predilected for having a lung or the liver hydrated cyst, and some are more prone to have a neurological, brain hydrated cyst.
Yeah, I don't know why. Yeah.
Yeah, I haven't come across anything like this in a literature also. There's a question from Kashif Farooq. All lesions were removed. Yes, all the lesions were removed, but unfortunately, few of the doctor says structure during this surgical procedure. And you have seen there's a lot of daughter cyst on the petri dish. They have removed almost all the cysts, but with few of them were ruptured during the procedure. Doctor, okay. Okay, Dr. Faisal.
Why does it stop? Because you can't get rid of the cysts. The albendazole will keep the cyst from growing, but as soon as you stop, you haven't killed it, no? That's why you have to either do a pair or surgically remove. Albendazole won't kill the daughter cysts within the.
Okay, thank you very much. And for that,
Okay.
from our side.
Thank you,
Dr.
Thank you.
Faisal.
Hafiz.
Thank you.